Hi guys, welcome to another edition of Virtual Care Camp. This one is getting to Swan you, not just a bird, my friends. We're going to go over some basic hemodynamic concepts. So what is cardiac output? Cardiac output is the amount of blood pumped by the ventricles each minute, or in 1 minute. It is determined by taking your heart rate and multiplying it times your stroke volume. Normal value is considered 4 to 8 liters per minute. So an example of this, or it's actually equivalent of an organ the size of your fist pumping 2 to 4 2 liters of Coke every minute. Stroke volume is the amount of blood ejected from the left ventricle each time your ventricle contracts. It's the difference between your end diastolic volume and your end systolic volume. Normal stroke volume is between 60 and 130 milliliters per beat. End diastolic volume is the amount of blood in your left ventricle at the end of diastole, and end systolic volume is the amount of blood in the left ventricle at the end of systole. When stroke volume is expressed as a percentage of your end diastolic volume, it is referred to as ejection fraction. So a normal EF for your left ventricle, as you probably well know, is 50 to 70%. Of course, that is textbook. So what is cardiac output, or how does size matter to cardiac output? So values are relative to the size of a patient. Say you have a patient who is 5 foot weighing 100 pounds, and you have another person who is 6 foot 200 pounds. A cardiac output of 4 may be adequate for that 5 foot person, but it probably will not be adequate for a 6 foot person. Another example, so let's say you have an 80-pound elderly woman. She will need significantly less cardiac output than a 350-pound young male linebacker. So if both of them had a cardiac output of 4 is normal, but for that linebacker, that 4 is not going to work. Cardiac index is actually, why we look at this is because it's more specific to the patient's body size. It is determined by dividing your cardiac output by the body surface area. So when they get a patient in open heart, they are always looking at height and weight, and this is why. So we can determine what the cardiac index is. And it's just simply, as I already stated, your cardiac output divided by your body surface area. Normal cardiac output, or textbook, is 2.5 to 4.3 liters per minute. And in the open heart population post-surgery, they kind of teeter around 2 to 2.5. But that's not normal, so usually we'll take a look at their hemodynamic parameters and try to fix that to get it to that 2.5 or better. So what determines your cardiac output? Well, we look at 4 determinants of that. We look at heart load, preload, afterload, and contractility. And we're going to take a closer look at each of these factors. We're going to talk about Frank-Starling's law. It describes the relationship between myocardial muscle length and your force of contraction. It's the amount of stretch directly affected by the amount of fluid volume in the ventricle. Preload most directly relates to fluid volume. As your preload increases, your cardiac output will increase until the cardiac output levels off. And if the cardiac output levels off, any additional fluid that's added will make your cardiac output fall. So think of a slingshot. The farther your slingshot is stretched, the farther the stone will travel. If the slingshot is only slightly stretched, the stone will only go a short distance. So if the slingshot is repeatedly overstretched, it will become weak and lose its ability to launch the stone at all. So the slingshot functions best when it is stretched just the right amount. Neither too little or too much. And the same thing happens with your heart. It likes just the right amount of volume for that cardiac output. It doesn't like too much because then it's stretched too far. And it doesn't like too little because it's not stretched enough. So your heart rate, as we know, normal heart rate is 60 to 100. The actual heart rate is not as important as the systemic effect of the heart rate. So if your patient's heart rate leads to diminished perfusion like decreased level of consciousness, decreased urinary output, hypotension, prolonged capillary refill, new onset of chest pain, then treatment should be initiated. Some patients won't tolerate a heart rate of 120. Their blood pressure will be in the 60s. Obviously, they're not tolerating it well. Some patients will hang out in the 120s for days. The faster the heart rate, the more likely it is that the heart is consuming more oxygen. The faster the heart rate, the shorter the diastolic phase. So what happens during diastolic phase? This is when your ventricles are filling and your coronary arteries are getting their perfusion. Preload is the volume of blood that exerts a force or pressure, a stretch on the ventricles during diastole. It is the filling pressure of the ventricles at the end of diastole, or it's the amount of blood that fills the ventricles during diastole. It's determined by the amount of venous return. Venous constriction, venous dilation, and alterations in total blood volume all affect your preload. Preload decreases with volume changes. Decreased preload, for example, is a result of things like diuresis, hemorrhage, diarrhea, vomiting, third spacing, any redistribution of blood flow, and diaphoresis. Increased preload can result from excessive crystalloids, administration and excessive blood product, administration during renal failure, or venous constriction. Clinical indicators of preload. So what do we look at to see what our preload is? First off, your right ventricle pumps blood into the pulmonary circulation, and your left ventricle pumps blood into your systemic circulation. Right ventricular preload can be referred by CVP or right arterial pressure. Your left ventricular preload is defined as either your pulmonary capillary wedge pressure or your left atrial pressure. So moving right along, afterload is the resistance to ventricular emptying during systole. It's the pressure resistance the ventricles must overcome to open the aortic and pulmonic valves. So you see your little heart picture there. He's working so hard. He must have a high afterload. As your afterload increases, the heart must work harder to eject the volume. Afterload is increased in things like aortic or pulmonic stenosis, hypothermia, hypertension, classic shock states such as cardiogenic, hypovolemic, or obstructive. Afterload is decreased in hyperthermia, distributive shocks such as septic, anaphylactic, neurogenic. Administration of vasodilating drugs reduces your afterload, such as nitro at higher doses, nipride, calcium channel blockers, or beta blockers. Clinical indicators of afterload. It can't actually directly be measured, but we actually look at the SVR as reflection of our afterload. SVR, or systemic vascular resistance, if elevated, the left ventricle faces an increased resistance to the ejection of blood. If the SVR is low, the ventricle faces a low resistance to the ejection of blood. Administering fluids or vasopressors, or you might want to treat the underlying cause. So what's normal? Well, we consider 800 to 1200 normal. So if it's low, what does that mean? It means that there is low resistance, or we refer to them as dilated. If it's greater than 1200, there is high resistance, or the patient is vasoconstricted. In your spare time, you could calculate the systemic vascular resistance by taking your mean arterial pressure, subtracting your right arterial pressure, or atrial pressure rather, times 80 times cardiac output. Afterload reduction. Medications can reduce your afterload, so nitroglycerin at higher doses, nipride, calcium channel blockers, beta blockers, and also your intra-aortic balloon pump therapy. That is actually what it's designed for, to help the heart not to have to work as hard. The balloon pump actually helps your aortic valve open and close. So preload, as you can see, they are putting volume's going into the heart, right? Afterload, it's the resistance to get that volume out. So here's just another picture. A lot of people are visual learners, so here you go. Contractility, it is the strength of the myocardial contraction, or the degree of myocardial fiber with contraction. It contributes significantly to cardiac output. Electrolytes have a major impact on contractility, and other factors include oxygenation or ischemia and amount of functional myocardium. Reflected indirectly by SVI, or stroke volume, adjusted according to body size, so it's your stroke volume index. So how do we get all these numbers? Because nobody's whipping out a calculator for your SVR or your stroke volume or things like that. Well, generally, if they're wanting to look at all these items, they may insert a Swan or a PA catheter. I've seen them do this on patients with ARDS. Open heart patients all have Swans in. PA catheters are frequently inserted to assess cardiac and respiratory function, as well as to guide your fluid and vasoactive drug administration in the critically ill patient. It can be inserted in most large diameter veins. The jugular is usually the most common, but I have seen subclavian swans. I have seen femoral swans. So this is what a Swan looks like. If you look, hopefully you can see this, but it has points 1, 2, 3, and 4. If you look on the diagram of the heart, so the proximal port is located just inside that right atrium, and then you have your port to the thermistor, which is where the temperature is measured, number 2, and then number 3 is the port to the balloon, and 4 is your distal port. We'll talk about what each of these do a little bit more. Just another diagram of what goes where. The balloon port, is the green line. And you can see they even have a green push pin on there, and you can see that they've got their balloon blowed up. The red is the thermistor, the temperature. PA distal, they have, it's actually distal. And infusion ports on there as well, and you can see where it's pinned. So what is the PA distal? It measures your pressure at the tip of the catheter in the PA. It actually measures your pulmonary artery pressures. So for your systolic, your top number, 15 to 30, is textbook normal. For your diastolic, 4 to 12 is textbook normal. With proper inflation of the balloon, it can measure pulmonary capillary wedge pressure. We'll show a little video of that later. And it is also used to sample SpO2 levels and other blood sampling needs. Your proximal lumen, it measures pressure 30 centimeters from the distal tip, so it's back from it. It's usually sitting in the right atrium. It measures your CVP and right atrial pressure. And these words are actually synonymous terms. This is the injection site for your cardiac output determinations, and it can be used to draw blood samples for laboratory tests requiring venous blood. If coagulation studies are needed, make sure there's no heparin in your syringe. It's used for IV fluids, drug administration, only if necessary, because there's actually another port that you can put those things in. Proximal Injectate, it looks like this. It's the blue port. This is where you will inject to get your manual cardiac output. This must be turned on if you're doing the H method to get a CVP. Or you have to, if you have the H, you have to have it turned on. If you don't have the H, you have to have a pressure line to it. Your proximal infusion port, it is just that. It is for infusion, and it is white, just like that. Your cardiac output port, thermistor lumen, this measures your blood temperature near the distal tip. When connected to the cardiac output computer, it can be used to monitor body core temperature continuously. It does give you a Celsius number. Down in CVICU, they have cheat sheets within each cabinet, and it has a Celsius to Fahrenheit scale on it. The balloon inflation port looks just like this. It's got a little syringe usually attached to it. It can be inflated periodically with 1.5 milliliters of air to obtain wedge pressures. Do not do a wedge pressure unless it's ordered, and sometimes your pulmonologist will do that, because it can, if done incorrectly, can rupture the pulmonary artery, especially if it's blown up inappropriately, say using 2 cc's or more than the 1.5. In order to inflate the balloon, you have to line the arrow up. you should always, when you have a Swan, you should always keep it locked, like this picture shows the Swan locked. Never have it opened or lined up because it can accidentally get inflated, and then you're sitting there wedging, you don't even know it. You could possibly cause pulmonary infarction if it just randomly wedges and stays like that. The other thing is that the Swan should come with a syringe that only opens 1.5 milliliters. In this picture here, it's pulled back 1.5. It won't pull back 2, although it looks like it's big enough to do that, but it will not go past the correct amount of air. So it comes in the Swan kit when they're putting it in, and this should be the only syringe that's attached to your Swan. And also, so I not only keep that port locked, but I have my syringe no air in it, completely emptied out. I have the plunger at 0. So I was made a reference to the H. The H looks like this. You can see on this H, they actually have, we used to just use one pressure tubing, and now they're using 2 pressure lines to monitor both the pulmonary artery pressures and the CVP at the same time, which is nice. But the H, should you only have one pressure line, would allow you to turn it off on to get your CVPs. Usually we would continuously monitor the pulmonary artery pressure, which is your PA distal line, that's the yellow line on the left. And so to get your CVP, you would turn off to the yellow line and have the blue line on so you could read it. So how to measure a CVP with an H, like I just spoke about, you're going to have it off to the PA distal, which is the yellow. It was on the left, now it's on the right. The blue is going to be on because your proximal injectate is where you monitor your CVP at. Then on your monitor, this is what the pulmonary artery pressures look like. This patient's 35/19, may have just a little bit pulmonary hypertension, but this is expected in open heart patients. And this is what your CVP would look like. When the proximal injectate is turned on and the PA is turned off, you will get a single number, the CVP, in this case it's 7. Now with your SpO2 Swans, it's continuously giving you cardiac index, cardiac output information, but sometimes they will use a manual Swan, and this is where you have to hook up this syringe device that you see in the lower right corner to the blue port, and you will inject saline and measure cardiac output that way. And this is what the whole setup looks like. This is, you can see this is the syringe, it's hooked up to a bag of saline, and then there's your Swan. So again, you're going to use the proximal port of the PA catheter, the blue line. You're going to use 10 milliliters of normal saline, and that will inject it into the right atrium. The normal saline should either be room temperature or cold. Back in the day, they used to keep the saline in an ice bucket, but we just make it room temperature. A thermistor located at the tip of the PA catheter senses the change in the blood temperature, and so the cardiac output is calculated as the difference in these temperatures. So we're looking at a couple of videos now. The first one kind of shows how it looks inside the heart.
Invasive pressure monitoring, whether central venous, arterial, or pulmonary artery pressure, is commonplace in the critical care setting today. The clinician must maintain certain practice principles in order to assure the validity of data obtained. This video will review some essentials of invasive hemodynamic pressure monitoring, as well as present troubleshooting techniques specific to bolus cardiac output and mixed venous oxygen saturation monitoring.
Recent studies have suggested that there may be important educational deficits on the part of nurses and physicians with respect to invasive hemodynamic monitoring. We as clinicians need to do everything possible to ensure data accuracy. I think this is best done by education of every member of the multidisciplinary team, and by doing so, I think we have the best chance of helping our patients.
Invasive hemodynamic pressures are measured through a fluid-filled system. Therefore, pressure monitoring systems contain certain components. These include a fluid-filled source, IV tubing, pressure tubing, transducer, flush device, connecting cables, and monitor. One or more stopcocks are added to allow entry into the system. The purpose of the uninterrupted fluid pathway is to transmit the signal from the patient to the transducer, which converts the physiologic signal to an electrical one. The transducer is attached to the catheter with short, non-compliant tubing. Stopcocks should be kept to a minimum and used only where necessary. Initially, the tubing should be filled by gravity rather than under pressure. In addition to the tubing, all stopcocks should be completely cleared of air, and the vented cap should be replaced with non-vented dead enders as the line is flushed. Tighten all connections. The most common transducer in use today is disposable. All disposable transducers have been pre-calibrated and do not require any further calibration. A flush device is attached to the IV tubing and connected to the transducer. When pressure is applied to the IV solution bag, the flush device ensures a constant delivery of fluid through the line to keep the system patent. A pressure bag should be inflated to 300 millimeters mercury. This amount of pressure is necessary to ensure delivery of flush solution at the designated rate. Before patient monitoring is initiated, the disposable pressure transducer and monitor cable are connected. The transducer and monitor must warm up prior to connecting the system to the patient. The pressure transducer must be zeroed and leveled. As both zeroing and leveling procedures are usually performed at the same time, they are often thought of as one function. However, they are separate functions and serve separate purposes. Because physiologic pressures are measured relative to atmospheric pressure, the transducer must be zeroed to atmospheric pressure. In addition, the hydrostatic pressure exerted by the fluid within the system must be eliminated by keeping the two ends of the fluid-filled system at the same level. These two ends consist of the end of the catheter and a fluid-filled interface, that is, a stopcock within the fluid-filled system that can be opened to air. Typically, the stopcock, located at the transducer, is used to zero and level the system, although any stopcock within the system can be used for this purpose. The zeroing and leveling point is the air-fluid interface, the point at which the stopcock is open to air, not the transducer itself. The other end of the system, the catheter end, is estimated to be located at the patient's phlebistatic axis, a point located midway between the patient's anteroposterior chest wall and the fourth intercostal space. The air-fluid interface stopcock must be positioned or leveled at this position on the patient's chest. With the air reference stopcock leveled at the patient's mid-chest, the stopcock is turned off to the patient's side, which opens the system to air, atmospheric pressure. The 0 button on the monitor is pressed, and a pressure of 0 is observed on the monitor. This procedure eliminates the effects of both atmospheric and hydrostatic pressure influences in subsequent hemodynamic pressure readings. All lines, including arterial lines, need to be referenced to this point. Failure to maintain the 0 reference port level with a phlebistatic axis will result in inaccurate pressure readings. Keeping the air reference port level at the phlebistatic axis allows for accurate measurement of pressures, even when the patient's head of the bed is elevated up to 45 degrees. If the pressure values displayed on the bedside monitor are suspect, the system should be re-leveled and re-zeroed, and the dynamic response of the system checked. Testing the dynamic response of the fluid-filled system involves exposing the transducer to a sudden, larger change in pressure, and assessing how well it responds to that change and how quickly it comes to rest. This is performed by rapidly activating the fast flush device to produce a square wave on the monitor. A square wave is characterized by a sharp sudden rise, tops off, and then declines sharply. After the wave declines, there should be an undershoot followed by 1 or 2 rapid oscillations, indicating an optimal dynamic response. Such a system should accurately transmit hemodynamic pressures. An overdamped system will demonstrate a gradual descent to baseline with only 1 or no oscillations after the square wave. Overdamped waveforms are smooth with falsely low systolic pressure, potentially high diastolic pressure, and diminished or absent dicrotic notch. An underdamped tracing will demonstrate more than 2 oscillations or bounces after the square wave. These oscillations are usually of equal height. Underdamped waveforms give falsely high systolic pressure and falsely low diastolic pressure readings. If either an underdamped or overdamped tracing is observed, check the pressure system for air bubbles, extra length of tubing, and ensure the pressure bag is at 300 millimeters of mercury of pressure. One troubleshooting technique of pulmonary artery catheters involves assuring the proper position of the catheter.
To determine correct positioning of the pulmonary artery catheter, the clinician must look at the centimeter markings on the catheter, must determine correct inflation and wedging of the catheter. This chest radiograph shows a appropriately positioned catheter. You can see the catheter tip here, but I need to again underscore that proper placement is dependent upon checking the centimeter marking on the catheter and checking to see whether proper wedging of the catheter occurs with 1.25 to 1.5 cc's of air inflated in the balloon. This radiograph demonstrates a catheter that's been inserted perhaps too far. It has a technical limitation because the patient's left shoulder is turned toward us, but in fact you can see the catheter tip way out to this position. The first thing I would do if I saw a radiograph like this would be go back to the bedside, check the centimeter markings on the catheter, and see if the catheter is wedged permanently, or if not, how much air it takes to wedge the catheter, and then reposition as is appropriate.
An appropriate catheter tip location is confirmed if the pulmonary artery waveform changes to a wedge waveform with balloon inflation of 1.25 to 1.5 cc's of air. This means the catheter is most likely in the correct position. Balloon inflation should be performed slowly and only until a wedge waveform is obtained. Overwedging can be recognized on the monitor as a pressure tracing that lacks normal characteristics. Overwedging is to be avoided as significant harm to the patient could result. In the absence of pulmonary hypertension or other patient conditions that could predispose the patient to pulmonary artery rupture, obtaining a wedge pressure using proper technique will not result in high enough balloon pressures to damage or rupture the pulmonary artery. Do not keep the balloon of the catheter inflated for a prolonged period of time, and never leave the catheter in a permanent wedge position. Either occurrence could result in a pulmonary infarct. Detach the syringe and allow the balloon to deflate passively. Actively withdrawing the air from the balloon may result in damage to the balloon itself. Ideally, pulmonary artery and wedge pressures should be obtained when the tip of the pulmonary artery catheter is positioned below the level of the left atrium. This is referred to as West Lung Zone 3, in which both arterial and venous pressures are greater than alveolar pressure. As pulmonary artery catheters are flow-directed, most enter this zone naturally and allow accurate transmission of pressure through an unobstructed fluid path from the left atrium to the catheter tip. Certain clinical conditions can convert Zone 3 to the potentially less accurate Zones 1 and 2. These include hypovolemia and high levels of positive end expiratory pressure, heat, and catheter tip location above the level of the left atrium. Intrathoracic pressure changes during respiration influence hemodynamic pressures. All hemodynamic pressure should be measured at end expiration, when there is less influence by changes in intrathoracic pressure. When a patient is breathing spontaneously, the hemodynamic pressure should be measured just prior to the inspiratory dip. With controlled ventilation, the waveforms vary. End expiration now becomes the low point just prior to the rise with positive ventilator breath. This is where the hemodynamic pressure should be measured in the mechanically ventilated patient. Inflation of the balloon of the catheter with 1.25 to 1.5 cc's of air may fail to result in a change from a pulmonary artery to a pulmonary artery wedge waveform. This may be due to rupture of the balloon of the catheter, proximal location of the catheter tip in the pulmonary artery, or distortion of the pulmonary artery wedge waveform with giant V waves. Giant V waves generated by the regurgitant flow may even be reflected in the pulmonary artery tracing, as seen here. Bolus thermodilution is a method of determining cardiac output at the bedside using a pulmonary artery catheter with intermittent thermal dilution capabilities. A signal, a solution of known quantity and temperature, is injected into the superior vena cava, or right atrium, and the change in temperature over time is measured by the thermistor near the catheter tip, located in the pulmonary artery. This change in temperature is recorded as a curve. The area under the curve is incorporated into a modified Stewart-Hamilton equation for determination of cardiac output. Characteristics of a valid cardiac output curve include fast, smooth upstroke, representing rapidity of injection, 10 cc's in 4 seconds. Smooth downstroke, representing passage of injectate past the thermistor. The curve should start and end on the baseline. The area under the curve is inversely proportional to the cardiac output value. A high cardiac output is displayed as a brief curve, while a low cardiac output appears as a long curve. Here are two cardiac output curves with differing values. The lower value is inaccurate due to a prolonged injectate time. This produced a longer than normal curve due to a slower upstroke. The result is a lower than actual cardiac output value. Cardiac output determination by the thermal dilution method is only valid if the following principles are adhered to. There is forward blood flow. There is adequate mixing of the blood and signal, or the injectate. There is adequate change in temperature from the signal. And there is a steady baseline pulmonary artery blood temperature. Bolus thermal dilution should be interpreted cautiously in patients with the following clinical conditions: severe tricuspid insufficiency, low flow states, hypo or hyperthermia, cardiopulmonary bypass, shivering, concurrent rapid IV fluid administration. Technical considerations to ensure accuracy of cardiac output data include the following: appropriate catheter position. Assure a proper pulmonary artery and wedge waveform from the distal lumen prior to measurement. Appropriate technique. Injection should be smooth and rapid and within 4 seconds. Accurate measurement of temperature of injectate. Use an inline temperature probe. Accurate volume of injectate. Be careful when filling the syringe and ensure that the proper amount of injectate is used. Appropriate computation constant. This is based on the size of the catheter, injectate volume, and temperature of injectate. Consistent timing of injection. End expiration is used for reproducible values, and apply a consistent averaging strategy. Averaging should include at least 3 serial determinations within 10% of the median value. The new technology of continuous cardiac output eliminates most of the errors just described with the bolus technique. Proper placement of the catheter is still essential, however. The catheter tip must be centrally placed in the pulmonary artery, using 1.25 to 1.5 cc's of balloon inflation volume for obtaining a proper wedge waveform. The injectate port must lie in the right atrium, and the distal end of the thermal filament must be in the right ventricle. Mixed venous oxygen saturation, SVO2 values, can also be obtained through the use of a pulmonary artery fiber optic catheter. The catheter is attached to an optics module that houses light-emitting diodes. Wavelengths of light with differing absorption characteristics for saturated and desaturated hemoglobin are emitted from the distal tip of the catheter. The change in light is reflected back to the optics module. The computer determines the SVO2 value by analyzing the ratio of light that was sent and then reflected back. This catheter requires calibration prior to use. Follow the manufacturer's instructions for both in vitro and in vivo calibration. The calibration completed at the time of setup will remain valid and retrievable unless the optical module is disconnected from the catheter. Always disconnect the optical module cable from the monitor and not the catheter for patient transport. As with all pulmonary artery catheters, correct positioning of the catheter within the pulmonary artery is essential for accurate data. The signal quality indicator, SQI, or light intensity signal, is a good indicator of proper catheter positioning. Optimal range of SQI is within 1 to 2. An SQI of 3 or 4 may be due to any of the following: altered blood flow at catheter tip up against vessel wall, change in hemoglobin or hematocrit values, kinked or damaged catheter. If an SQI of 4 is present, verify that a wedge waveform is obtainable with 1.25 to 1.5 cc's of air. Aspirate and flush the catheter. Check and update the hemoglobin or hematocrit. Check the catheter for kinks. Clinical conditions that might also affect the SQI signal include blood administration, acute anemia, administration of lipids or other colored solutions. An SQI should be corrected before an in vivo calibration is performed. Correct in vivo calibration ensures the accuracy of the oximeter system. Perform in vivo calibrations as per the hospital's policy and procedure and follow the manufacturer's instructions. The patient's hemodynamic and oxygenation status should be stable for optimal calibration. Obtain a mixed venous blood sample slowly by withdrawing a blood sample from the distal port of the pulmonary artery catheter, approximately 15 seconds per 1 cc of waste sample and lab sample. Rapid withdrawal may cause aspiration of arterialized blood. The sample should be capped after all air has been expelled and analyzed on a co-oximeter. Follow the manufacturer's instructions on the steps to complete an in vivo calibration. Obtaining accurate hemodynamic measurements requires ensuring proper setup and maintenance of pressure monitoring systems, accurate cardiac output determinations, and mixed venous oxygen saturation measurements. In summary, a wide variety of valuable hemodynamic parameters can be acquired through the judicious use of pulmonary artery catheters.
Over my career, I've seen the ICU change. The severity of illness appears to be increasing. The time demands, the technological demands on the nursing staff and the physician staff have increased. It's still fundamentally important that proper time and attention is paid to the technical details of hemodynamic monitoring if we're going to get the very best information to help our patients.
Edwards Life Sciences Technical Support Helpline is available to assist with technical questions. Either call them at 1-800-424-3278 or contact your local sales representative to answer any questions concerning our products.
Alright, hopefully you're still with me, and I hope that you watched that video because I felt like they did a very good job of troubleshooting tips. And not just for the Swan catheter, they talked about the dynamic response, the square waveform test. That's good for arterial lines and that's good for CVP lines as well. If you have an overdampened arterial waveform or underdampened, it's good to do that square wave test. And so if your square wave test, if it's overdampened or underdampened, you know that you need to do some troubleshooting, like check for air bubbles, make sure the length of your tubing is appropriate, make sure that your pressure bag is fully inflated to the 300 millimeters of mercury. But the other thing is that, and I say this in balloon pump class, if you have an ICP, if you have intra-abdominal pressure, if you have a CVP, if you have an arterial line, you should be printing a strip out on your lines at least once a shift, because this can document if something should happen to that line, say the patient kinks it or something like that. You know, you will say you got it first on shift and now you have it something to compare it to when you're looking later. You know, hey, his waveform didn't look like that earlier today, but it does now, and you have something to compare it to. You have something that's reproducible, something you can show the physician when he comes in. So let's talk a little bit more about the manual cardiac output method. I think they did a good job of talking about it. This is a picture of what this screen will look like on your Philips touchscreen monitor. Up top there, that's where you can select or reject a wave, and down at the bottom is the actual wave. Before injecting, you're going to observe for a steady baseline temperature. You're going to observe the patient's respiratory pattern. You're going to begin administration of the injectate at end expiration, just like they were talking about, to decrease variance in cardiac output measurements. When you get your CVP measurements, if it's just a CVP line, you should do it at end expiration as well. So you're going to administer the bolus, which is 10 milliliters, rapidly and smoothly in 4 seconds or less. And if you have not ever injected for cardiac output before, there's a lot of pressure involved with it, so you kind of have to have a little bit of strength to inject. Again, another screenshot of what manual cardiac output method looks like. So this is a cardiac output curve. The picture is down below, and what you do, assess the cardiac output curve and value on the monitor screen. It must start at baseline. It must be straight, flat, non-wavering, line with a smooth upstroke and a gradual downstroke, like is demonstrated below. So what the AACN says about this is that if the saline is cold, then you're going to inject 3 times. If it is at room temperature, you should do it at 5 times. The reason for the variance is that cold is going to demonstrate more of a difference easier than your room temperature. So I think there's some literature out there to support that a cold saline is more accurate. The video, so A up there is a high cardiac output state, B is a low, and C is what normal looks like, and D is a faulty injectate, like it wasn't smooth or fluent. That's what that waveform looks like. But it also, there's many varying versions of not right. So up again at the top, you have that's pretty good. It goes up smoothly, comes down pretty smoothly. In the middle there, that's obviously not smooth. You can see that there's little divots here, there, and everywhere. And the one at the bottom also looks like they were barely injecting. It took them a while to get started. It's a prolonged waveform. It's not a good waveform. So this is, again, you see that the syringe is attached to your blue port there, your Proximal Injectate, and then you can see where the temperature is hooked into the manual Swan. It will give you temperatures as well, but it does have to have extra equipment for that. Now when we talk about your SpO2 Swans, this little guy I made, and he is attached to, I believe, every SpO2 monitor, but it's just a quick sheet. You are supposed to calibrate your SpO2 Swans every 24 hours, and you do an in vivo calibration. In vitro calibration is if the Swan is outside of the body. Like for example, if you're getting ready to put one in at bedside or something like that. And then on here additionally some good information. Your AACN procedure manual, it's that big purple thing. Page 113 refers to venous oxygen saturation monitoring continuously. 626 talks about your insertion of your Swan, and 648 is removal. 655 is a good troubleshooting page. So you don't even have to look in the index, it's right here on this handout. And also on here it walks you through the steps of how to do an in vivo calibration. So step 1, you're going to use the navigation knob. It's in the lower right of the Edwards monitor. And you're going to press the knob to display calibration menu. You're going to highlight the in vivo calibration, and then you're going to press the knob to select that. After 25 seconds, draw is highlighted, then you will press the knob just prior to drawing the waste and lab samples. Then you're going to use the knob to enter what your oximetry and hemoglobin or hematocrit values were on the labs that you sent off. In order to calibrate your SpO2 Swan, you have to have a recent, as in the same time or close to, ABG and CBC. So step 5, you're going to highlight calibrate, you're going to press the knob to select it, and then your new numbers will go in there. Usually if it's an open heart patient though, they are calibrated in the OR, so you won't need one till the next day. But again, the AACN guidelines are that the SpO2 Swan is calibrated every 24 hours. So you got a CVP, now what? What do you do with it? What do you want to know? I talked a lot about SVR, talked a lot about Afterload. How do you get that? So on your monitor, you're going to find this Hemocounts button here. You're going to hit that, and then it will bring up a screen that looks like this. Here would be the weight, the height's up there, your cardiac output on this patient's 5, heart rate, blood pressure, pulmonary, artery pressures here. So it's 36/19. You will enter your CVP here. So you'll touch that, put in whatever the value is, and then you're going to hit perform calc. So say it's 5 like it is over here. You'll put 5 in here, hit perform calc, and then it will generate an SVR. See, this person's SVR is 1183, so it's normal. So other things we look at the waveform of our pulmonary artery, or our Swan. This little squatty short one denotes that it's in the right atrium. Usually if it's tall and thin like that, that says right ventricle. The other thing Dr. Bouchon used to tell me, if you have something like 30/2, like some fairly significantly decent number over a single digit, he said it is probably in the right ventricle. Then you have your pulmonary artery form here. You can see your diacrotic notch, all that good stuff, and then your wedge pressure. Again, this is just another picture of what normal looks like. This is normal, obviously, the cute highlighted pink up there. Tall and thin right ventricle pressure. Okay. Your pulmonary artery wedge pressure, you can see an A wave and a V wave. And I think that is about it. If you have any questions about Swan-Ganz catheters, or you just want to come in one day, go down to like CVICU, because they do get the most of them, give me a call and I will be glad to like do some real-time education at the bedside. So next there's 4 case studies, and I would like you to complete, in addition to just a couple of questions. And also let me know if you found this of any value. Thank you. that's all, folks. So if you have any questions, just let me know. Thanks.